Hi, I'm Brent Beasley. I'm the Medical Director for St. Luke's Care. Today we have with us Dr. Nathan Laney, endocrinologist in the St. Luke's Health System. Nathan is our champion of the Basal Bolus order set. Now this is a fairly new order set over the last year or so that we've brought out to help guide the primary care doctors and internists in our health system on taking care of patients in the hospital who have glucose management issues. So welcome, Nathan.
Thank you.
Nathan, just kind of to lead out, a couple of questions for you. Why do we need to change the way we're currently doing insulin in the health system?
Well, Brent, although hyperglycemia is generally an asymptomatic condition in most individuals, during acute hospitalizations, it's not a benign condition. There have been multiple studies that have shown that hyperglycemia can be associated with prolonged hospitalization, increased rate of infections, as well as mortality in these patients. And although it's a frequent comorbidity for patients with acute hospitalizations, it's often mismanaged in the hospital setting.
Well, tell me, is there evidence that there's a better way?
Yes, there have been several studies over the last several years that have highlighted or investigated how we are managing diabetes in the inpatient setting. There were a couple articles that were published in 2006 from the Journal of Hospital Medicine that looked at internal medicine services managing diabetics. One of these was a retrospective chart review that highlighted the poor follow-up of diabetes treatment throughout the hospitalizations of their patients, and all of these patients had pre-existing diabetes prior to their hospitalization. In most of these patients, up to 96% actually had diabetes listed as one of their admitting diagnoses, but only 62% of diabetes was mentioned in their daily progress notes, and only 20% of the discharge notes on these patients actually provided the patients with discharge diabetes instructions, which highlights that the diabetes was not followed throughout the hospitalization.
So we will not recognize it when they first come in, and even during the hospitalization when we know the patient has diabetes, we're not doing a lot about it.
Exactly. And even though hyperglycemia was fairly common, occurring in more than 70% of these patients in this retrospective review, only 34% of these patients actually had their treatment adjusted throughout their hospitalization. There was also another study that was also published around the same time that was actually a prospective study looking at hospitalist services in a large academic setting, and basal insulin was only ordered in about 43% of these patients, and short-acting insulin was only ordered in 4% of these patients for their diabetes management throughout the hospitalization. And even though 65% of these patients had either one hyperglycemic or hypoglycemic episode during the first 5 days of their hospitalization, none of them had any changes made in their diabetes management.
Nathan, one of the things that I've thought a lot about, I've written in our newsletter, is this issue of sliding scale insulins. When I was a resident 20 years ago, I started my internship, the sliding scale was what we put on the chart of every single patient. I know even in the last 10 years, endocrinologists and even in different journals that I've read have been saying we need to put an end to sliding scale insulin. So talk to me about sliding scale insulin. Why is that not the best way to take care of patients?
I think we have two landmark cases that have come out in recent years. These are known as the Rabbit-2 trials. The first one was actually published in September of 2007, and it actually looked at 130 non-surgical internal medicine ward patients that had pre-existing type 2 diabetes. And basically, they randomized these patients into receiving basal bolus correction insulin versus sliding scale insulin. And clearly, the basal bolus correction treatment group that were getting a basal insulin plus mealtime insulin, they had greater improvement in their glycemic control when compared to the control sliding scale insulin only group. The sliding scale insulin group had higher mean fasting glucose levels during their hospitalizations. They had a mean glucose overall throughout their hospitalization, and they even had higher mean glucose levels during the last day of hospitalization, which clearly shows that the basal bolus correction was superior to managing the sliding scale only patients that we have typically seen in previous years for diabetes management.
And you said this is both in medical patients, and there was another study in surgery patients.
More recently, we had the Rabbit-2 trial looking at surgical patients. This was a slightly larger study, and it utilized patients that were scheduled to undergo elective or emergent surgical procedures, but those patients that weren't severe enough to be expected to require an ICU stay after their surgery was performed. All of these patients, again, had pre-existing diabetes for at least 3 months, and they randomized them again into basal bolus correction insulin with Lantus and Epidra versus sliding scale insulin. Those were your two groups. And again, the same overall effects were noted between the two patient groups.
So not just is the sliding scale not as good, but we're actually seeing improved outcomes.
The basal bolus correction actually had lower rates of wound infections, and although not significant, statistically significant, there was decreased rates of pneumonia and acute renal failure in those treated with basal bolus correction.
That's good to know. Well, why don't you at this point take us through, if you would, the order set, the different components that you feel like are really important, things that the physicians, we want to make sure the physicians always do or always think about on it, and maybe if there's some wisdom you can give us on how to think about the whole issue of insulin dosing.
Be glad to. So our basal bolus correction insulin treatment algorithm was designed to make sure that all diabetic patients received consistent diabetic care throughout their hospitalization, and all the details that are involved in appropriate diabetes care were covered. There at the beginning, at the top, is the diet section, which is of paramount importance whenever you're dealing with a diabetic patient. You want to make sure that you've put them on an appropriate diet. And since the diet orders have changed in the St. Luke's Health System to a consistent carb, away from the American Diabetic Association diet, we've put that on there so that all of the treating physicians have the opportunity to remember which diet they're supposed to mark for a diabetic patient.
Well, that is a change, and let me stop you right there and just ask a little bit about consistent carb. What's the difference between the consistent carb versus the ADA diet?
There really isn't a large difference, except now in the consistent carb, we're looking more at the carbohydrate intake rather than the calorie intake that was the previous focus of the ADA diet. Carbohydrates are clearly your source of sugar from your diet, and that's what we're trying to adequately cover with our mealtime insulin. So placing a patient on a consistent carb ensures that they are limiting their carbohydrate intake at each meal.
So in the old days, I would have written 1,800 calorie ADA diet. What's that going to be in a consistent carb diet?
In a consistent carbohydrate diet, that is a 75-gram consistent carbohydrate diet.
Wow, that sounds like something I'm going to have to remember. Is there any easy way of making sure we always get a 75-gram?
Well, the nice thing is that if you just mark a consistent carbohydrate diet, that's the default is 75 grams consistent carbohydrate diet.
That's good to know.
In general information, there's other things more for nursing orders to cover your bases to make sure that physicians are notified if treatment or diet is being changed so that you don't have to remember to write that in your orders every time that you are taking care of a diabetic patient. It also has nursing orders in that general information section that make sure the nurses know how to appropriately administer the different types of insulin as far as timing in regards to meals and such. There's also a place in there that if you need assistance with your diabetes management, you'd like the endocrinologist to come along and assist in the management, you can clearly mark it right there and not write a separate order for assistance in managing.
Do you find you get many general internists or consulting endocrinologists on the management of the diabetes right now?
Not frequently, but occasionally when they are difficult cases, having problems with frequent hypoglycemia or inability to get the diabetes under control, sometimes endocrinology is asked to assist in the management of the diabetes.
Okay.
Also in here, we have gotten from the very beginning of the hospitalization an area where you can get the diabetes educators involved with the patient. That is of utmost importance in managing a diabetic, especially if the diabetic could potentially have treatment changes that are going to occur following this hospitalization. Mm-hmm. Diabetes education, we have limited resources, and there aren't very many educators in the hospital system, but they are very willing and try to get to all the patients as timely as possible. And if they know about the patients earlier, they can get in to assess the patient's needs closer or longer before the hospital discharge rather than the day of, where it makes it more difficult for the physician to facilitate appropriate discharge plans for the patient.
So that's a good reminder for me. When I go to write insulin orders, if I'm just doing it without an order set, I'll probably forget every time to order a diabetic education, but if it's already on there for me, that's good. It's going to be helpful to me.
Yes, and I think it serves as a reminder. If you don't feel like the patient needs education, you don't have to mark it. It's just there, serve as a reminder, and the ability to get a diabetes educator earlier if you'd like.
Okay.
There's also an area in there where if you want to cancel previous insulin orders, just have to mark it. You don't have to discontinue particular insulin orders. But more importantly, there's an area in there for you to mark when you want to be notified about high blood sugars and low blood sugars, essentially giving you parameters. Personally, I like to know if any of my patients are experiencing hypoglycemia with a level less than 70. And if someone is persistently having elevations, I will also like to know so that I can intervene earlier as far as making adjustments in my diabetes management for a patient.
Makes sense.
And so rather than giving a fixed parameter to be contacted, we leave this up to the treating physician to make a decision of what they feel is the appropriate levels for that particular patient.
And I guess I would come back to this issue that you mentioned in the previous study of the general internist or the admitting physicians. Too seldom we're going back to the chart and making adjustments in insulin. You as an endocrinologist, that's what you're there for. You're looking at it on a daily basis. Mm-hmm. But that also tells me I ought to be looking at it on a daily basis too.
Definitely, insulin should be reevaluated every day, and if there are any consistent patterns, changes should be made so that the appropriate care can be given to the patient to get their diabetes under control.
Okay.
Glucose monitoring. There are different ways to approach glucose monitoring. You can do it at fixed intervals, such as every 4 hours or every 6 hours. Generally, if you're going to do those intervals, you generally want someone to be getting continuous enteral nutrition or continuous IV nutrition, or someone that's on an NPO status. You want to make sure that you're following them regularly so that you can make adjustments in their insulin therapy. That being said, most of our patients are not NPO or on continuous tube feeds and are on a regular diet. So it's important to remember that when you're managing diabetes, you want to be checking the blood sugars before each meal and bedtime so that you can adjust your short-acting mealtime bolus insulin and your long-acting basal insulin. And so that is there as well. And there are other options of changing around your glucose monitoring that I don't think are necessary for us to go through right now, but that you do have the flexibility to monitor the blood sugars how you think best fits your particular patient.
The next section there is talking about the transition from IV insulin to subcutaneous insulin. And besides that, we also need to talk about just starting a patient on insulin de novo, which really is a lot of the patients I find that I put in the hospital have not been on previous IV insulin. So those two issues, if you kind of take us through about how do I decide how much insulin to use?
Yeah. The reason that we really went in here to add the basal and bolus mealtime insulins in here is because oral agents are probably not appropriate during a hospitalization, metformin especially, because a lot of patients that are ill or not tolerating a regular oral diet may become dehydrated, develop acute renal insufficiency, which is a contraindication to using metformin. Additionally, in the hospital, we're doing lots of radiology testing using IV contrast. Again, you have to hold metformin therapy for at least 48 hours after IV contrast. So in general, it's best to avoid oral agents, especially the other ones that can precipitate hypoglycemia, such as your sulfonylureas like glyburide, glipizide, glimepiride, and so on. So when diabetics come into the hospital previously treated with oral agents and you are having to still manage their diabetes, it's best to start them on a basal bolus correction insulin order. Basal insulin being your long-acting insulin, and your bolus insulin, which is designed to be your mealtime insulin to cover the carbohydrate intake at meals. It's really important to estimate the appropriate amounts of insulin on individuals. And so in order to kind of help physicians try to figure out the appropriate doses, we've actually given some education tools for them to try to estimate the amount of total daily insulin a patient should receive in a day. We've broken it down into patients where the A1C is normal or unknown versus patients that come into the hospital and they have a known elevated A1C. In general, you probably want to be a little bit more conservative with your insulin therapy in somebody that you don't know their A1C or they've had a previous normal A1C in recent 3 months. In those individuals, you might approach them by taking their weight in kilograms and dividing that by 2. and then that would be their total daily dose of insulin.
All insulins combined together.
All insulin in total daily insulin. And from there, you would divide that by 2 and split that 50% into the basal insulin and then 50% as their bolus insulin. Out of the 50% of bolus insulin, you would divide that by 3 and separate that equally over your 3 meals. So that's one easy way to kind of estimate your insulin needs in a patient. But again, that's something that you have to reevaluate on a daily basis and determine if that amount of insulin was adequate or if they need adjustments more or less.
And as you point out, we have an education sheet on that that's bundled with the order set for the physicians to use, and it kind of takes us through exactly how to do that calculation. So again, another tool that's helpful to us.
Yes. Now, although we have previously used the word sliding scale insulin, which we would like to get away from now because basal bolus correction is the more appropriate term, there is the opportunity to add additional insulin to meals and bedtime if desired to correct high blood sugars, which is what we call correction insulin.
Okay.
We've given 7 pre-specified levels or scales for correction insulin that are pre-printed in the order sets, as well as one additional section that could be individualized per the treating physician's preference. Again, it's difficult to assess what somebody's needs are when they first come into the hospital. So just like we used weight to estimate somebody's total daily insulin dose, you can also use somebody's weight to kind of estimate what their correction insulin needs might be to treat high blood sugars that could occur during hospitalization.
And that's going off the assumption that a heavier person is going to have more insulin resistance,
Correct.
needing higher doses.
Correct.
Okay.
And so that is also included in the basal bolus correction insulin order set. It's listed underneath the correction algorithm, different correction algorithms, so that it can serve as a tool, just a starting place for you to evaluate where you might start somebody safely, and then on a daily basis reevaluate, and you can adjust your correction level if necessary. It's important to note that in general, we try to give bolus insulins prior to meals. We don't want to routinely give it before bedtime, but hyperglycemia is not a benign condition, as I previously stated. So if somebody is hyperglycemic with an elevated blood sugar at bedtime, it is possible in the order set to mark it so that the nurses could give correction insulin. In general, again, we're trying to be safe with that, so it is also ordered that we only give bedtime correction if the blood sugar is above 200. And we also recommend that the nurse check blood sugars again at midnight and 3 a.m. to preemptively catch any hypoglycemia that may occur because of that.
You mentioned hypoglycemia, and I know that we have a hypoglycemia order set that is bundled with the basal bolus order set.
Correct.
So that we have that extra help for the nurses when a hypoglycemic episode occurs. But with a basal bolus approach, am I likely to see more or less hypoglycemia in my patients than I would with the old way of a sliding scale or nothing?
I would anticipate probably less frequently, although there were some mixed results from the Rabbit-2 trials. In the medicine ward non-surgical patients, there were episodes of hypoglycemia, although rare, but the rate happened equally in the basal bolus correction and the sliding scale insulin groups. In the Rabbit-2 trial, there were more episodes of hypoglycemia that occurred in the basal bolus correction group versus the sliding scale insulin only group, but our goal overall is improved diabetes care, avoiding hyperglycememia, and in both of those trials, basal bolus correction was clearly superior in keeping better control of the diabetes during hospitalizations.
It's good to know.
But again, it requires daily reevaluation of the blood sugars, and with daily reevaluation, you should be able to anticipate any changes that could occur and adjust your insulin appropriately before any hypoglycemia occurs.
Nathan, are there other studies or things you wanted to bring to the discussion today that we haven't covered so far?
I think those were most of my studies that I think are important that we really took into account when we were trying to put together these basal bolus correction insulin order sets. I do think that it's important to point out, though, that there are more treatment approaches to diabetes than just subcutaneous insulin and oral agents. one of the newer modalities that I think physicians will see more and more frequently during hospitalizations is subcutaneous insulin pump therapy.
We've started seeing these even in the hospital wards, and most of the time I don't know what to do with them when they come.
And that's not uncommon because mostly endocrinologists are the ones that are managing subcutaneous insulin pumps. And in fact, it is St. Luke's health system policy that endocrinologists manage subcutaneous insulin pumps during the hospitalizations. There is actually an order set in St. Luke's Care that the admitting physicians can print up and place on the chart that automatically consult endocrinologists. The endocrinologist will be contacted by the nurse, and we will provide further orders for the subcutaneous insulin pump orders.
So you make it easy for us.
Yeah.
I appreciate that.
That's no problem.
Nathan, I really thank you so much for taking time to be with us today. The amount of information you've brought to us is very helpful. Not only that, you're championing this order set, the amount of time you spent talking to physicians, going out and where they actually practice has been really over and above what most people have done. So thank you for all that you've done to go forward with glucose control in the health system.
That's no problem. Appreciate it.
Have a good day.